gets caught. When I go to a physician or a nurse or any other health provider, I am a co-producer. That's why the topic of salutogenesis is so important, because people actually matter, either in their decisions to seek care or in compliance or in general in adopting healthy lifestyles or in transforming their objective conditions so that they promote health. So those are the boundaries. Then we have the question of what are health systems for, the second question. We usually focus on health improvement, and that is indeed the defining goal. The defining goal of a health system is to improve health. But we must also include at least 3 other intrinsic goals. One is the distribution of health. The goal of a good health system, we're talking about the whole health standard, is not just to increase the average level of health, but to improve the distribution. You can actually, I can show this arithmetically, and I can show it to you in many examples, increase the average level of health in a society while increasing the gaps and inequalities. That's not a good health system, okay? So that's a second intrinsic goal. Third, you can increase health and even distribute it better and treat people very poorly. You can lock up people with infectious diseases. Look at all the hysteria around Ebola, just as a very present example. You can, sterilize people who are carriers of a defective gene, and you will probably improve health, but that's not a good health system. So another goal is to be responsive to the legitimate expectations of people, that they will be treated decently with respect to their inherent rights in the course of healthcare, and we can talk more about this. And then finally, a good health system distributes the financial burden across all society, which means it doesn't rely on people paying out of pocket, because out-of-pocket payment is the most unfair way of paying for care, because it makes the sickest pay the most. And since the vast majority of episodes of ill health are not people's fault, and access to healthcare is not part of the reward system, it's a condition for all other rewards to be fairly distributed, then a good health system protects and distributes the burden of financing the health system in a fair manner, which means that people contribute according to their economic capacity, not according to how sick they are. So those are some elements in terms of thinking of the goals of what is a good health system. And then how do we fulfill those goals? Well, every health system has to perform 4 key functions. One is provision, and that's what we tend to focus, and that is indeed the core function. At the end of the day, there's a service that gets delivered. But there are 3 other enabling functions: financing, and there are better and worse ways. Resource generation, I'm going to talk about the key resource, which is human resources. And then very importantly, and this is one that's, I think it's particularly important for what we're talking about today, which is the function of stewardship. Stewardship means setting strategic direction for the system as a whole, providing fair rules of the game, regulation. What drugs can you sell? What do you need to open a hospital? How do you, what licensure you require to treat patients, etc. But very important part of stewardship is mobilizing intersectorial interventions that act on the determinants of health. And so, whereas the Minister of Health is not the Minister of Transportation, it is his or her responsibility to persuade the Minister of Transportation to, like Mr. Lalonde did, enforce laws about seatbelt use. Whereas he or she is not the Minister of Finance, it is his or her duty as part of the stewardship function to persuade the Minister of Finance to raise taxes on tobacco, because that's the single most effective intervention. And that's part of the stewardship role, is key for healthy policies, not just health policies in the strict sense, but healthy policies. Finally, let me tell you about that key that I put in red, the human resources. A key function of a health system is how do you generate the resources, and that's technologies and information and physical facilities, but the key is human resources. I had the honor of co-chairing with my colleague Lincoln Chen a commission on the education of health professionals for the 21st century, which was published in 2010 to mark the 100th anniversary report. A report that was called Medical Education in the United States and Canada, and that shaped the way that first medical education and then the education of other health professionals got structured all over the world. And I'm not going to give you, because I'm out of time, anything about that, but just emphasize 3 ideas. The first important idea is the need to really embrace competency-based education. The traditional model The starting point is the curriculum. The curriculum usually reflects the interests of the faculty and the way they themselves were trained. So, heuristics are very powerful instruments for social reproduction of values and ideas. And then out of that, you get some educational objectives, and that's what you assess. In competence-based education, you put this model upside down. You start with the question of what are the health needs of the people and the requirements of the health system, as I've defined it. And that would include, understanding that health needs involves health promotion, not just treating sickness. And out of that, you develop competencies as the outcome, which is what you assess. And once you know what's the outcome, then you design a curriculum so that you achieve that outcome subject to assessment, so that then you go back and satisfy the needs of people and the requirements of the system. And I'm getting an alarm that says that I'm out of time, so I will wrap up very quickly. Second idea, this is one idea of the report, competence-based education. The second one is inter- and trans-professional education. We have educated people where they go to common pre-secondary education, but once they go into the university, each goes into a different silo. That's the dominant model, and I know the University of Toronto has done a lot of innovation here. But the complexity of tasks in the health system is such that you require teamwork, and yet nothing in your educational experience prepares you for that particular competency, which is to work as a team. Again, very central to what we're talking about, because that team is not just among professionals, it also goes trans-professionally to the non-professional part of the workforce, community health workers, and then to other health professions, other professionals who are not health professionals, but who do a lot of work on health, like lawyers and economists and urban planners, and developing the competencies to work as teams where the objective is to promote health in this comprehensive way should be part of the way we educate health professionals in the future. And the last idea is really to embrace the notion that there are 3 levels of learning: informative learning, formative learning, and transformative learning. And informative learning is very important. It's about sharing information. The outcome is to produce experts. Very important. We want people who are really experts in whatever they're doing. But that's not enough. You need formative learning, which involves socializing the experts into a set of values, which in the case of professionals are an ethic of service, a code of conduct that's oriented towards service. And that is the difference between an expert and a professional. And that is very important, but it's not yet enough. We need to go to the 3rd level, which is transformative learning, where the competencies are leadership attributes, so that our students, when they go out, become change agents. And being change agents means that you understand not just the content of your work, but the context of your work, the larger system in which you operate, and you develop the leadership competencies to transform the context, to make sure that you strive in your practice as a professional for better arrangements and for following this gold standard around health systems. Let me finish with one last thought. When I was Minister of Health, in Mexico, I was trying to have an integrative framework, because I grew tired of all these divisions we do between determinants and care and all of that. And I found, and this is the law we wrote, that the concept of social protection in health offered such a framework. So social protection, if you think about the protection of the health of people, has 3 main elements. First, protecting against health risks. And that itself has 2 elements: protection against environmental risks, to which you may be passively exposed, like environmental pollution, or urban squalor. And it also involves protection against behavioral risk, where you are actively exposed, like smoking. So that's one element of the notion of protection. The second dimension is the protection of patients once they have healthcare, where you protect the quality of care, both the safety and effectiveness, but very importantly, this concept of responsiveness that I talked about. And then financial protection. You need to stop people from becoming bankrupt because they get sick. And a good health system is one that tries to integrate all of those elements. Most people that have studied the Mexican reform talk about the insurance scheme that we did introduce that now has 58 million people enrolled, all of whom were uninsured. And Mexico is on the path to achieving fair financing and better quality of care. But few people know that parallel to that, we also created a whole new public health agency that was charged, and it's called the Federal Commission for Protection Against Health Risks. And that was charged with all of the upstream interventions. And very often we do downstream reforms to improve the financing or the quality of care without understanding that if we don't have a parallel upstream reform on the determinants of health, the system will become unsustainable. Because once you extend insurance, which is very important, you don't want people going bankrupt because they get sick, but you remove a financial barrier to demand will grow. If you also improve health quality and protect patients, it will grow. So if you don't simultaneously do something to stop people from getting sick in the first place, the system will become unsustainable. But also, if you do the first type of protection, you will also achieve a healthier population. And that's where I see the theme of the summit integrating fully in, rather than thinking that these are separate or alternative models. I do think it's a comprehensive and integrated model that we need to strive for, where we look both at all the forces that promote health, material conditions that people live in and to which they may be exposed passively, and we try to transform those so that they are truly salutogenic, their own behaviors and lifestyles, but you can't do one with the other because you cannot preach to poor people to eat well when they live in conditions where there's no form in which they can access or purchase healthy food. You at the same time create a responsive health care system, and you assure fair financing for all. I think if we achieve all of that, we will be getting closer to that very elusive, until now, gold standard for health systems. Thank you very much.
Thank you very much, Dean Frank. I think Dean Frank, through his example as Minister of Health and his work as a scholar, has really showed us some core ideas and demonstrated that they can be implemented. And this is really something I think that's spread now through the world as models. And if there's anything that his frameworks have been, is infectious and really sets us up for a range of reforms all over the world. So I'd like to invite you to take a seat, Dean Frank. And for our next speaker, I'd like to invite Dr. Kibrom Haile Hagos. He's the medical director of Emmanuel Psychiatric Hospital in Addis Ababa, which is the only hospital specializing in mental health in Ethiopia with a population of 90 million people. You know, you think of James Brown saying he's the hardest working man in show business. Dr. Hagos has his work cut out for him. He graduated from the Joad program of Addis Ababa Toronto University Psychiatry Residency Program and has gone on to work on many initiatives in Ethiopia, including the decentralization of psychiatric services to underserved regions by assigning psychiatric nurses to 57 health centers to open and oversee psychiatric clinics in these areas. Dr. Hagos, please come up.
Good afternoon. I'm very excited to be here in Toronto because I was trained by extraordinary people from the University of Toronto. Dr. Claire Payne is here. She's a witness. I will talk on our health system and how we are trying to work with it. So when we discuss about ideal health service, I wouldn't say there is something called like ideal. I would say workable. And what's workable for one setting will not be workable for other settings. So I will talk about what has been workable for us. So my talk will mainly be about efforts being in the face of meager resources, which are helping us to deliver health care system to the broad mass. Our population is 90 million, not 9 million. So it's a huge population. And our human resources are limited. So how are we supposed to reach all the people with all these limited resources. So in order to address this, we are employing health extension program. I will tell you how the primary care system, primary health care system is organized in Ethiopia. So we have health centers which deliver basic primary health care. So they are supposed to serve about 25,000, and they are coordinating and organizing community health services as well. So they are supporting, supervising, and giving technical support to 5 health posts, which are manned by 2 health extension workers each. So the main philosophy of the health extension program, which is considered as the flagship of the primary health care in Ethiopia, is empowering the community. That means if the right information and skills are given to households and individuals, they can safeguard their own health. That means they are serving as vectors. So they are taking health messages from the policymakers and the higher levels of healthcare to individuals and households. These are people who are at least 10th grade complete, and they are trained for about 1 year on how to deliver healthcare. So we have about 38,000 of them. So they are mainly working on outreach services, going house to house and delivering services like family planning, immunization, main preventive health care, disseminating health information, and so on. So they are utilizing strategies like model families. That means families which have accepted the information they are and who are trying to implement them will influence other families. They are also implementing community involvement. That means they are penetrating into the associations, community associations that already exist in order to disseminate health information. And they are also working at health posts. That means they are giving family planning, immunization, and other services in this, such as delivery, in these health posts. So with this healthcare system, as an opportunity, we can reach the community so that they can safeguard their own health by taking the information, all the information that's given to them. Regarding mental health, we are trying to implement a program called MHGAP program. That means Mental Health Gap Action Program. So the principles are decentralization and integration of mental health into the primary health care level. So we are kind of trying to close the treatment gap. That means about 90% of the needy population with mental illness are not being treated. So we have about 50 psychiatrists for a population of about 90 million. So in order to address the vast needs of the population with mental illness, it's almost practically impossible with the existing psychiatrists or other professionals who are trained in mental health. So what we are doing is to integrate mental health care into the existing primary health care so that we can access to the wide population. So the strategies are utilizing task shifting and utilizing the existing healthcare infrastructure, which is reaching almost all of more than 72% of the population. So in the process, we are training people who are working in the primary health care, such as general practitioners and health officers who are working practically in the primary health care system to deliver mental health care at the health centers. That can be extended to each households by using the health extension workers as vector. That means they can do with training, they can do basic rehabilitative work, they can do case detection and referrals, and I think mental health can reach the most needy at their very house. So I would say that our enablers are, we have the right strategy, there is political commitment, and there is support from partners such as the WHO, who is funding most of the funds for the mental health gap intervention program. However, we have challenges as well. There is poorer coordination between various levels of health sector management. So in order to sustain the programs that we are having, it needs continued efforts. There are also inconsistencies in implementation from one region to another. There are regions who are doing well, reaching a coverage of 100% with the existing system. There are some regions who are lacking behind. So there is inconsistencies in implementation throughout the country, and these are our challenges. Finally, I would like to recommend 3 things which every health system could implement. The first one is public participation and ownership. That means enabling the population to produce or cultivate their own health. By doing so, we can access everybody or the whole segments of population, and we can provide easy access of the community to health care. So the health care is not waiting for patients or clients to come. It's knocking every door and mobilizing people and showing them the way or the entry points towards the existing health care system. So the other one is appropriate allocation of public health funds. As you know, Ethiopia is a resource-limited country. So we cannot allocate the limited resources that we have into expensive and sophisticated health infrastructure. But it's not just for us, for all kinds of countries or richer countries even. I think appropriate allocation of public health funds for health promotion and preventive activities will be paying off more than investing them in curative cares. That doesn't mean curative care is not important, but priorities are to be given to public health and preventive issues. The other one, third one, is affordable and accessible services. That means it's not just the healthcare infrastructure that brings the difference. It should be accessible and affordable to the community. Otherwise, it does not make sense. You are kind of trying to establish a system for people to use it, and it's not accessible or affordable. That does not make sense. So I think affordability and accessibility is very important. So these are the 3 things I recommend that any health system employing. Thank you very much.
All right. Thank you very much, Dr. Hagos. It's amazing to see the ingenuity of countries that are working under fairly constrained systems and the potential for other more resource systems to learn from that. I think the collaboration between University of Toronto and Addis Ababa University over 10 years now has led to some amazing exchange. So now I'd like to, speaking of learning from other settings, I'd like to invite Dr. Jose Carlos Prado Jr. He's the General Subsecretary in the Rio de Janeiro Health Secretariat. He's trained as a family physician and is currently doing his PhD in public health. He served as superintendent of the primary health care at the city of Rio de Janeiro and as a technical consultant to the Department of Primary Care in the Ministry of Health. The experience of establishing family health teams in Brazil and its spread, a dramatic spread, particularly in the city of Rio, has been an inspiration to me, working in family health teams in Toronto and in Ontario. And we'd like to invite Dr. Prado to come and speak.
Thank you very much. Good afternoon for everybody. It's a great pleasure being here and having the opportunity to speak, to summarize in 10 minutes 5 years of a great reform that our city is living now since 5 years. Brazil has a huge population. We have 200 million people, and Rio, the city of Rio, in the southwest part of Brazil, has 6 million of people. So in 2009, only 100,000 people had access to primary health care. So it represents 3.5% of coverage of primary health care. So when our mayor was elected in 2009, he had the opportunity to visit some Olympic cities, including London, including Vancouver, I think, and other cities around the world. So he saw almost in all the cities the same health systems model. So a primary health care very, very strong, coordinating the care, and a health system well organized. So in Brazil, it is we started the improvement of the dispensation of primary health care since 2000, maybe. Our health system is universal in Brazil, but it's very, very, very young. Our constitution with universal system, health system, is since 1988. So it's very, very, very young. In 2009, Rio had the worst results, the worst indicators among the cities, the capitals in Brazil. And it was obvious because it wasn't possible to continue making the same decisions. The results would be the same. So our mayor was convinced to change the approach, to change the goals. So he started investing funds in primary health care. Now we have 45% of coverage in primary health care. So 3 million of people was included in 4 years. So it's very impressive, but we have too much challenges with this decision, because you must guarantee good satisfaction of the population. If population doesn't like this model, the mayor won't be elected. So the politicians need good results. So each clinic, each new clinic for us, we cared like a child. So it was very, very important for us. The opinion of the politicians, of population, of the people who has the opportunity to form opinion was very important for our model. So we started with a big program of formation of the physicians. In Brazil, we have only 3,000 of family doctors for 200 million of people. So in Rio, in 2009, we had only 20 places of residence program in family physician. So we had to improve this educational program. We try to make the programs of the three universities stronger. So this was what we did, and we opened our own places of the family doctor program of residence. Now we have 142 places per year. So it's a big number, but it is small for the challenges in our city, because the city is very, very, very huge. In 2016, we will reach our goal is 1,500 teams of workers in primary health care. Each team is composed by a family doctor, a nurse technician, and 6 community agents. So there are people from the community, and they work for these teams. Our model is a little bit different from other countries. We have dental care also, and we have an area, a restricted area of population covered by the primary health care. It made the difference in our city, because if we started improving these teams, we have now 200 of health centers. If it was open for everybody, maybe we didn't improve these teams, because the pressure would be very, 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 very high for these teams. So we made areas of coverage, and these areas, a team was responsible for 4,000 of people for everything. And the principles of Barbara Starfield, we try to apply day by day, including the coordination of care, the longitudinality, the first contact. So some other efforts were necessary. We made a chart, a book of all of the procedures included in this chart, because we had lots of clinics that didn't make suture, for example, vacuum, for example. It was terrible. It was very difficult to make offer a good primary health care with these conditions. So this chart was very, very necessary for us. So now everyone make all the procedures included in this chart. So it was very important for us. Another way we have decided is implementing the pay for performance in our teams. So it was important for inducing for good practical of care. So the indicators, the goals are almost all of them not only quantitative indicators, but usually they are rates like satisfaction of people, like the percentage, the percent of people covered almost by the same family doctor and other indicators. So we could decentralize the money we pay for the system, and it was very, very, very important for us. So we are going to, okay, time is over, but it's a great challenge. We know the challenges, but we know where we want to go. So in 2016, we reached 70% of coverage in our city. In the first years, we had improved the coverage for poor people, but we believe that this model must be for everyone equal in our city. So thank you.
Thank you, Dr. Prado. When you think of the elements of a health system that treat illness versus creating health, it's really interesting. I just think of Dr. Hago speaking about model families. So families that seem to have it right and showing using networks to teach others. And in a family health team that has 1 doctor and 6 community health agents, you can see that the shift between treating illness and promoting health can be transitioned significantly. So that's fascinating. Now I'd like to invite Dr. Xiaolin Wei, who teaches in public health at the Chinese University of Hong Kong, who's trained as a physician and was a classmate of mine during his PhD in health services research here at the University of Toronto. He was previously a senior research fellow in the Nuffield Center at the University of Leeds and a national consultant to the China National Development and Planning Commission for Primary Care Reform. So now we're taking you to the other side of the world to another spectacular reform, particularly in the area of restructuring health systems and insurance. Xiaolin, please come up.
First, I would like to thank the chairs, co-chairs inviting me to speak here. It's a great honor. And I would say I get infected. I wanted to talk about, the China, but I know that China is a very big scale. It runs the largest healthcare in the world with 1.3 billion population. I wanted to point out 2 kind of tools and then go down to the enablers and the barriers. I think for all the developing countries now, they're moving fastly towards universal health coverage. And then after universal health coverage, lots of countries are trying to implement or establish a primary care oriented health system. So the 2 things are happening in China. So if you look at China's health reforms since 2004 until now, there are nearly kind of $1 trillion invested, additional money. And 50% of the money was invested into the health insurance schemes. And then the other about 30% money invested into primary care facilities and providing preventive public health care package. And those money are also given to the primary care facilities. So I'm going to talk first about the health insurance. I think the biggest challenge and also biggest achievement of China's health reform is to set up the rural health insurance schemes for nearly 100% of the 150 million population. So it has set up from like 5% in 2003, and now it increased to about 98% by 2013. So I think the enablers would be, the first is kind of political commitment, actions from both the central government and also the provincial government. The way is called the matching methods, with the local governments have to match central government rural health insurance scheme subsidies, and also have to match with the rural household contributions. So that is a way to enableize political wills and then the will of the families together. Another thing I would say would be a functional health system. So if you look at China in the rural areas, it has a county hospital, the township hospital, and village doctors. And this kind of functional system enable that people with health insurance will be able to go somewhere to get their services. Again, there are lots of barriers. I think the first barrier about universal health coverage in China would be a kind of fragmentation of the schemes. You'll see a kind of downward about benefit schemes from the government employees to company workers, to city dwellers without any job, to farmers. And the second is that there's no sufficient coverage for the outpatient service. Up now, there's about like 50% outpatient is paid by out of pocket. And for some disease episodes we have done research for, it's up to 80%. So let's go to the next stage. The primary care oriented health system reform in China happened since 2009. The aim is to look at how we could establish family doctors and their teams as the future housekeepers and health managers of the patients. So one of the most important approaches is to make public health service available and equitable for all. The government began to infuse a per capita based funding for public health service that coverage free chronic disease management, health education, immunization, maternal child health, mental health, communicable disease, prevention, reporting, etc. This is kind of per capita based, and it has doubled the money for the last 3 years. So that money is given to the primary care facilities. So that has changed the financing landscape about the facilities. So they got a large amount of money. And after that, the government also had implemented the National Essential Medicine List. You know that traditionally China has relied on the drug markets to financing the health facilities. And now in the primary care facilities, only medicines on the list could be prescribed and no markups are charged. Since 2011, the main reform is looking at how to set up the GP model reform. So to strengthen the capacity of the general practitioners. So most of the general practitioners in China are kind of, substandard, and they did not get well payment. So the future is to say that they should get at least 5 years and graduate MBBS training plus 3 years standard residency training. So after that, they would get MBBS and also a specialty in family medicine. The second is to look at GP service team. That will be a team of a doctor and a nurse, and they are trying to enroll residents in their catchment area and to form the long doctor-patient relationship. So that is continuous care. So that has been piloted in 10 cities since 2011. So we did research look at patient assessment of quality of care using the Johns Hopkins internationally validated tools. So after that, we found the enablers of the primary care-oriented health system would be, first is kind of institutionalize the funding for preventive care package in the government. So that has been earmarked in the government, and it will be increasing no less than the rate of the GDP. So that is achievement. And secondly, is a kind of strong workforce of general practitioners, nurses, and public health doctors, because that needs long commitment and trainings targeted at different levels. It started from the in-service training, resident training, and then we'll move to the vocational training, getting the faculties established. And the third is policies have to really taking care about forming the long-term relationship between the residents and the GPs. So in another way, that is how to form the continuity of care, which is essential after you have reached universal health coverage. So we can see that key enablers would be like capitation payment to GPs to take care of those who are enrolled, and also a service package that could address local health priorities. For example, chronic disease management package in an elderly community, or the maternal child health in a city full of migrants like Shenzhen. And another thing is to abolish the user fees, because user fees we have seen compared in different cities, see that is a big barrier for people to access primary care. Again, we see the barriers. The first barriers in primary care would be a kind of lack of leadership and the government commitment at all the levels, because people take care more about tertiary care, building big hospitals, and it's good for politicians to show their achievements during their tenure. But primary care needs long-term attention and commitment. And the second would be a vast but weak workforce in primary care in China. I think that is common in every country. And the third one would be the separation of acute care and primary care, public care, healthcare services, because we have seen that the new funding for public health services, mostly of the services are actually provided by nurses. They're normally at a different floor of the community health center, providing all the kind of tables, etc. And the government assessment of the primary public health care is more on the formalities rather than the quality of care. And doctors sitting in their consultation rooms providing adequate care without sufficiently address, prevention, smoking cessation, weight watch, etc. The last thing I would say that a lack of change in big hospitals, because of, there are lots of political maneuver about big hospitals right now. It has not changed much since 2009. So it's still fee for service and no effective referral system. So I will end up here. Thank you very much.
Great. So to tie the morning and the afternoon together a bit more closely, you've described a series of challenges. I think Julio's told us that health systems are neither a black box nor a black hole, and not just a laundry list. But there's a series of activities that we want systems to engage in, that we want to promote health in some way, we want to treat disease, and I think our Dean Howard Hu is very keen on the idea that we need to integrate across primary care, or rather clinical services and public health. But this third thing that Alex has brought us is really how to include the generation of health as one of our goals. Could you comment in your experiences in your own systems, and maybe Julio across the systems that you've looked at, how do these come together? Where are the opportunities for intersection in the delivery of these services?
Well, I'll just say briefly that I think we need to reconceptualize primary care, precisely to do that. In the original conception, part of the reconceptualization is to go to the roots. It very much had this notion at its very heart, the notion of mobilizing all spheres of policy to promote and improve health. But gradually, and if you look at the Alma Ata Declaration, that's a very explicit element there. Gradually, primary care became primitive care. And that's not what primary care should be. And, it was the least prestige in most of the health systems. The really good doctors would not go there, and nurses. So the idea of minimalist, very primitive, I think is what we need to get out of. And first of all, it also does not correspond now to the much more complex epidemiological profile. And I think the idea of very basic packages, that has a long tradition since the 70s and 90s and 80s of minimalist packages, and that would be primary care, mostly provided by unsupervised, poorly trained community health workers. That's how primary care degenerated into primitive care. I think a lot of the examples we have heard, and certainly the experience in Mexico, has been to try to get away from that and have a much more integrated view, primary care as the core of the health system, which is much better suited to anticipating and to dealing with this much more complex epidemiologic picture, including the emergence of chronic illness. Because the big shift in that has happened with the epidemiologic transition is the human experience of disease has changed. For most of the time, it was a sequence of acute episodes. It was episodic, one episode of an acute illness, you either died or recovered, only to get sick of another episode. And that's how we develop most systems, including primary care. Instead, being ill has become a condition of living. And managing chronicity becomes a very important part of what we ought to expect from primary care. But primary care is also the perfect way, and I think this is Howard's strategic view, where you adopt a population perspective. Now, having a population perspective is the core of public health. That is the essence of public health, is that it understands populations or societies as a whole. And when we can introduce that population perspective, and I certainly know, especially the Brazilian case, well, which is exactly that, and I think increasingly some of the other examples are, where the primary care network is responsible for the care of an entire population. And that requires you to anticipate and not just to be responsive. And to me, the essence of primary care is that it is anticipatory. And that means it anticipates larger needs than just responding to episodes of illness with minimalist packages, which is where primary care went for the most of the 20th century. I think if we're going to reinvent primary care, it has to, first of all, recover the idea of a population base where you are responsible for the entire health of the population, and that means interventions at the intersection with other spheres of policy at the local level, a lot of the salutogenic interventions that we've been talking about, and that's where it coincides. Interestingly, in Obamacare, as the reform is called in the United States, there's the central feature is what are called accountable care organizations. And that's a very interesting idea, which if it's well implemented, and that's a very big if, but if it is well implemented, will lead exactly to this vision, because you will have organizations that are accountable for the health of an entire population. And because that's what defines public health, that's where you get primary care as the focus, where you integrate clinical care, because primary care also has to respond when people do become sick, with a population perspective that's inherent in the essence of public health. And that's a very different primary care than what we've been used to in most parts of the world.
Yeah, I agree that primary healthcare should be given by well-trained people.
I think
There's a microphone on.
So there could be various stages of healthcare system according to the level of resources that you could have. The most important thing I see is that there should be a system of referrals. For example, primary healthcare at health center level is given by general practitioners or health officers. Health officers are people trained at a degree level, but they are not medical doctors. Also, it's by nurses who are trained to a degree level. Various capacity building programs are given to them according to the need. But I wouldn't say that's adequate. What we have is appropriate referral systems that not all people need a general practitioner, for example, or a specialist. So according to the needs, there is a system of referrals. It does not end there. So next to the primary care, you will have general hospitals, and above that, you will have specialized hospitals according to the kind of the complexity of the cases that are referred. So having appropriate referral systems and supervisions and mentorship are available. I think the health systems can work efficiently. It doesn't have to be people trained to a higher level, you know. That will require time and many other issues. So, for example, we are training lots of medical doctors currently being trained. So it takes time, but there will be a shift to a higher level. But currently, I think a lot of work is being done with all the resources that we have, and I want to reflect on that.
Now, we actually have one other respondent who's online. Hopefully she can come in. This is Malavika Sharkar, who couldn't get her visa. There you are. Hi, Malavika.
Hi.
Hi. So she's a professor and director of research at the James P. Grant School of Public Health at BRAC University. She's a Bangladeshi physician with a master's in public health from Harvard and a doctorate in public health from the University of Heidelberg. So Malavika, we're running a little late here. So we're wondering if you could, as opposed to give a full comment, maybe give some of your comments on how you think the functions of integrating public health and primary care and creating health can come together in a health system like Bangladesh's, which has had spectacular results in the last decade.
Thank you. Actually, here it's 1:33 the morning.
Okay.
So, but it was wonderful actually listening to everybody. And I just want to start my comments referring to what Dean Julio Frank said, that there's the enabling factor. There have to be stewardship from the government, and Bangladesh is an example. The institution, pluralism, the other intersectoral development like women education, women empowerment, but also there should be like a locally produced evidence or research, which ICDDRB is a great example. So I agree that there is a transition, that epidemiological transition, but I think the problem is much more serious for a country like Bangladesh, where it's a triple burden of disease. It's not, we have not got rid of tuberculosis yet, or diarrhea. Of course, we are saving life through our DOT or oral rehydration, so like a demedicalization of the treatment. But now there's epidemiological transition, the non-communicable disease, but also the traffic accident, which is actually much neglected public health in developing country. So the one of the major success for Bangladesh was community health worker. I think it's very well known, and it was acknowledged in the recent Lancet series. We have 219,000 community health worker, but as Professor Julio mentioned, that this is like a primitive primary care, because these are the women with 6 years or 7 years education, with little supervision, various model of incentive like pay for performance or paid or volunteer, and they are not kind of, with all due respect, that ready to handle this complexity of the current health situation, particularly non-communicable disease. So just one of the initiative I would like to mention that government recently started this community health clinic provider. They started 18,000 community clinic all over Bangladesh. They were provided with laptop and Wi-Fi internet and the built-in web camera so that the telemedicine can be actually provided, telemedicine services. But the problem is in Bangladesh is, like I was listening to China presentation, that to reach universal health coverage, that in Bangladesh, 64% is out-of-pocket expenditure, and 97% of it actually to the private sector, which is mushrooming, unregulated, poor quality of care, with the rapid urbanization and the political not instability. I would say that, like, this one of the interesting twists in Bangladesh that urban health is actually overseen by local government, not the Ministry of Health. So there are a lot of twists in terms of providing the care, so that the program we have been very proud for, like that's mostly actually rural, not the urban area. So if we want to have an universal health coverage and ensure equity, we need a nationwide the safety net, the health insurance system. And the major challenge is Bangladesh, the informal sector, but also this very poor financial literacy. So I would say that that definitely what Julio Frank finished his talk saying that the three different of protection, the quality of care, the health risk, environmental and behavioral risk, financial protection. And when I look at current Bangladesh, although we are very proud of our exemplary achievement, like providing good healthcare at low cost, but we are in a transition and we really have to look forward and we need further progress in Bangladesh with all its shining the past and the public, the community-based approach. And the innovation in terms of the social innovation, adaptive innovation, or technological innovation, that further progress actually going for a really health insurance, because that's the model and that's the goal we are looking for. Because another, I just want to again repeat Professor Julio Franks, that it's about the intention of good health. It's not, it does not have to be the health, but I think the most important, the challenge for Bangladesh is actually now, how can we start a health insurance program in Bangladesh, because every year around 5 million people trapped into poverty because of the catastrophic expenditure. So that's the way to forward. And I know that in Bangladesh, the government, the NGOs, the donors, this institutional, the pluralistic environment that exists in Bangladesh, they are working hard. And I'm hoping for the bright future. In particularly, hopefully in 10 years, we'll have another Lancet series on how to encounter, address non-communicable disease and traffic accident. Thank you very much. Yeah.
Great, thank you very much. So now I'd like to open things up for some questions from the audience. That's a very good question. I don't know. I'm not sure if there may be a timing issue. Are there any questions for the panel or any comments? I'm not sure if we have an answer. Malavika, there's a question about...
Yes.
Yeah.
Oh, what's the question? Could you please repeat the question?
The question was, why couldn't you get a visa? But
well, because my passport is traveling in Singapore.
Oh.
So the Canadian visa now, actually we get it from Singapore. So I'm in Bangladesh and my passport became global globetrotter.
Oh, I see. All right, thank you. Any questions from the audience? So we have a breadth of experience from a range of different systems, each of which are dealing with a different set of challenges. Go ahead.
Hi, name's Jason Hirsch. In the past couple of months, we've seen the World Health Organization encourage the embrace of traditional medical knowledge. So I wanted to ask for the panelists, I wanted to ask, as you've been building your primary healthcare systems, how you've dealt with the question of leveraging both the knowledge and the networks of traditional medical systems. and bringing that integration.
Any comments? Go ahead.
Yeah, I would like to introduce about China's experience. Traditional Chinese medicine has been a very big branch in China, and it has been kind of fully integrated into the primary care facilities and hospitals. So in the primary care facilities, you can go for acupuncture. And if you have back pain, you can go for massage. If somebody have the stroke, and they can be discharged from the hospital and then get the physiotherapist treatment from the TCM doctors. So also you can get herbs there. So there's an integration. And if you go to the upper level, to the tertiary hospitals, the TCM doctors can read X-ray scans, can prescribe you both TCM medicines and the Western medicines. So there's a kind of full integration of the traditional medicine.
Thank you.
Abdullah, do you have a question? I think maybe get a microphone.
Okay, thank you.
Go ahead, sir.
I work with the Canadian National Institute for the Blind. I have a question for Dr. Frank. Dr. Frank, I haven't heard anywhere today the word rehabilitation used. Where do you think rehabilitation fits into the ideal healthcare system?
It's a great question. The concept I think we need to move is into the entire continuum of care, and certainly with the epidemiologic transition and this idea of moving from episodes to conditions of living, conditions, by the way, which are very often stigmatized, and obviously mental health is the example, but other chronic illnesses, which, by the way, some of which are infectious, like AIDS, right? So it's not that it's only non-infectious diseases or non-communicable diseases, but we need to fully embrace the concept of the continuum of care, which starts, with some of these upstream interventions that we were talking to stop people, and includes once, the diagnosis and treatment. It includes certainly rehabilitation and restoration of function, and to my mind, increasingly needs to also include palliative care, even in very poor settings. And we haven't talked also about that, but a good health system encompasses the entire spectrum. Today, for example, this is something my wife works a lot on. Probably the most unequally distributed variable I have seen across countries is access to effective pain control in terminal patients. And this is not a problem of rich or poor countries. I mean, this is a problem of inequality across the world in degrees that, when I saw the data, I couldn't believe them. So including the right to a dignified death free of unnecessary pain and suffering, I think a good health system encompasses the whole spectrum. And certainly rehabilitation occupies a huge part of a segment in that spectrum. That's what, the move towards chronicity as opposed to episodic care has to do. But that requires a major reengineering of health systems. So the answer to your question is, I think it's very important in this idea of the continuum of care.
Abdullah?
This is a question for Dr. Sarkar before she falls asleep or gets cut off or goes to Singapore. What accounts for the very impressive improvements in health outcomes in Bangladesh over the past 2 decades, seeing that the country is beset by so many problems, not the least of which is poverty and disorganization and corruption in government and so on? How has that been possible?
So there are 5 reasons, I would say. One is that the stewardship of the government. Government was very much explicit about the partnership with the NGOs, but also has a very supportive policy, and the institutional pluralism, the government, NGOs, the donors. So there is also generous external assistance from the donors. The third is there is a joint effort of the whole program was actually women-centered, equity-oriented, and high priority, the national targeted health issues like the vaccination, the family planning, the tuberculosis, diarrhea, awareness. The fourth is the particular focus on not only the health, what the Dean Julio Frank mentioned, but women education, the microcredit, the women empowerment, and the last is the culture of the locally produced research and evidence. And all these were actually facilitated because of this, the brigade of community health workers, the thousands of community health workers who actually make sure the participation of the community and the sense of ownership, the problem identification, and in terms of resolving those problems. And the last thing I want to mention, definitely that lot of innovation. I can actually talk hours if I can describe the different kind of innovation. And just to mention that, like BRAC, the organization, the university I'm working for, the BRAC has started this community-based eye care program. So this community health worker, how to diagnose presbyopia using thread and the picture, and providing eyeglasses, which has changed the life of the community. And I recently had one old person, 80 years old person, told me that, do you know, I can read Quran now. And it was amazing for me. So this type of the technological, social, and adaptive innovation, which actually brought the success in Bangladesh. And we are resilient, that's for sure, as a Bengali.
Thank you. In light of the time, I'm going to take two questions with some short answers. So Howard over here, and then yourself. But we do have breakout sessions where you'll be able to discuss a lot of these issues in more detail. My apologies.
Thank you. This is a question not for any particular member, but whoever wants to answer it. It relates to perhaps an unaskable question that I'd like to pose here. In one of the things that was discussed is the issue of trust, and also Dean Frank brought up the issue that he led the Lancet Commission on in terms of health professionals retraining. And it relates to what actually motivates the ideal primary practitioner, if you will. And in my experience as a medical student when I was in rural part of Colombia, was that one of the ideal community health worker models was how villages and towns all got together and selected the ideal person they wanted to then go into the cities for training, because that person had the trust of the community, was known to be an upright, standing person, etc. And I contrast that with a number of reports recently in the Lancet about as China goes through the health reforms, there's huge distrust of Chinese medical practitioners, even fights breaking out in the clinic. And on the other hand, we can look at something like the Commonwealth report, which just came out, which showed how the national health system had perhaps the highest level of patient satisfaction recently because of the reforms in a salaried system in the UK. So with all these different kinds of considerations, I wonder if some have some reflections about how to actually attract the highest quality, most trusted people into the primary care health system and for training.
Okay, I think there are several initiatives that can be chosen. Good salaries are very, very important, of course. So in Rio, for example, we try to put some very, very good salaries. So a family doctor, it's like in dollar here, 20,000. A family doctor can reach 20,000 reais. For us, it's a good, very, very, very good salary. So what? How much? 20,000 of reais. In dollars, 10,000. Month for a month. Okay, so for Brazil, for Rio, it's a what? $10,000. It's a good salary. And for our residents, we pay half of this So we pay 10,000 reais for the residence program in family doctor. The other residence programs, we pay 4 times less of this. This is an induction for forming family doctors, because in our country, being a family doctor isn't the first choice for the students, the medical students, because of the salaries, because of people don't see as a good specialty. So this is a point. Another point is making good conditions for working. So our units, new units, are very, very, very interesting for working. They have everything that they need. This is another important thing. The pay for performance is another induction that was very important for us. So people is paid more for good results. This is very, very important. And we opened our units for the undergraduate, for the students in medicine, nursing. So we offered the best units and the best physicians to, they see day by day that physician, they can make their opinion, and they can think, oh, I can be a doctor like this doctor. So we have lots of initiatives in Rio that they are very interesting, because it's a big, very, very big challenge getting 140 students that want to be a family doctor, and we had reached 70% of the places with residents. So for us, it's a good result.
So I think we're out of time. I apologize, but we will be moving into breakout sessions, which will allow us to explore these things in a lot more detail. I don't know if we can get that up on the board. So what we've heard is a series of different experiences, different challenges, and we'd like to sort of help this frame a series of more in-depth discussions with our external vectors, but also internally. And so the things that, I don't know if we can get that up on the wall. Yeah, it's coming. Is to look at some of the themes that have come up already. So the first is around strengthening the collaboration of health systems. We talked about different silos and how we work across them. So there's experience from different systems on how this is done. This will be done in Auditorium B. There'll be a session on strategic alliances. So if we think of the people who treat disease and the people who promote health and the people who might create health, well, how do we pull them together? Who are these folks? What are the structures within systems that will bring them together? The next, and this, the person from the CNIB would be happy, that we have an outbreak on ability, inclusion, participation, and its place in the discourse. So how do we include people who are marginalized? One of the key elements of primary care is its reach and the fact that it's the first contact. Well, one of its goals is to improve equity. How do we do that? How do we ensure that happens? And the last one is about what does the 21st century healthcare provider look like? And here the idea is, what is the skill set that's required of someone who's going to bridge these different areas? And as you can see in different health systems, the requirements will vary, but there's probably a core. And I think Howard's comment about trust and the character of those individuals will really be at the core of that. So I know we're supposed to start at 3, but if we can maybe take a 15-minute break, you can come and chat with the folks up here if you had a burning question you couldn't answer, and then we will convene at 3:15 back in those different sites. All right? And thank you very much for joining our session, and please give our panelists a round of applause.